Welcome to HRS TV. My name is Fred Kusamoto, and I'm really blessed here to have my good friend, Professor Ali Otto from Ankara, Turkey. And he's going to talk to us today about the use of anticoagulation in patients with renal failure. So Ali, welcome.
Thank you very much for the invitation.
Absolutely. So the first question I have is, there's some controversy with regards to the use of anticoagulation in patients with renal failure. Can you give us a little background on that?
Well, in fact, this is not new. Over the years, we had the same concern and controversies for the use of vitamin K antagonists in patients with end-stage kidney disease and on hemodialysis. Because we know that the risk of stroke and also the risk of bleeding is higher in this group of patients. And we have one meta-analysis just as an example, showing that in patients with non-renal dysfunction, the risk of stroke and mortality is reduced by warfarin, but no effect on bleeding. But in patients with end-stage renal disease, then the no effect on the risk of stroke and mortality, but the effect, the bleeding is increased. So this is a very big meta-analysis of 50,000 patients. Well, we know that the DOACs have revolutionized the anticoagulation in patients with atrial fibrillation for stroke prevention. But we don't have enough data coming from the randomized controlled trials for use of DOACs in patients with end-stage renal disease. We have some post-hoc analysis of the big clinical trials, major clinical trials, and we have some real-life data and some retrospective cohort analysis showing all in the same direction. DOACs are also effective in stroke prevention, but in the same time, also effective in reducing bleeding as compared to warfarin.
Excellent. So it sounds like DOACs have been a really important advance over the vitamin K antagonists, and we all certainly like using them because they're a lot easier to dose and take care of. Although clearly there must be issues with regards to those patients in renal failure, right, with regards to dosing.
Well, this is very critical. As we know, the renal elimination, or in a general sense, pharmacokinetics of the DOACs are different. The renal elimination is the least with apixaban, the highest with dabigatran, from 20% to 80%. So based on this, of course, you need to adjust the dosage of the molecule according to the renal function level of the patient. We know that if the renal clearance is over 50 ml per minute, then you are on the safe side. You can use all the DOACs in full dose. Well, there are some minor modifications, for example, in terms of, in case of apixaban, but otherwise, the full dose can be used. But below 50, when it goes between 30 to 50 ml, then you need to adjust the dosage. If you go to, yes, sir.
No, I was just going to say, so the most recent, HRS guidelines and with the ACC in their update that talked about sort of apixaban versus some of the other drugs. What's sort of the data sort of behind that recommendation, and what do you think about the future?
Well, the recommendation for the DOACs in patients with renal dysfunction is class 2B. But for end-stage renal disease and patients on hemodialysis, only warfarin and apixaban can be considered according to the most recent guidelines. For the future, we need to have some data from randomized controlled trials, and I think most of them are ongoing.
Excellent, Ollie. Well, thank you very much for this. I really appreciate it. We can see how complex taking care of these patients with atrial fibrillation and risk for stroke and renal disease is such a big issue. And I recommend for everybody to go to HRS 365, and there you can see Dr. Otto's full talk with all the data and specifics in the management of the patients and the real data. So on behalf of HRS TV, I want to thank all of you for viewing, and Ollie, thank you very much for being here.
Thank you very much. I'm honored to be with you.